Boston Kpro in field grafts, my learning over 10 years.
So still there is a consensus on, some people still believe that PK is better in these cases. And you have a very good tissue supply, you have a very good quality tissue supply. Because what I feel after doing, say, about 14 years of DALK or various technique, I think DALK is basically giving temporary euphoria to the surgeon, that moment. Otherwise, if you see long term, like whenever you have like this patient in one eye and complicated you have tackled in a different way, and one eye PK long time back, and I have patient like 17, 18 years, PK with 900 cell count, and this DALK also the cell loss is also faster. Cell loss is not like natural cell loss. It is almost 2.5 times faster than natural cell loss. So one eye is like 900, one eye after say 13 years is like, but the interface after a long time, the patients when they are intelligent enough, and they will tell that no, this is, I have seen patient in Mass, recently I went to Mass, and I have seen the PK of 44 years, same tissue. I requested them to get the specular and see what is the specular was 600 something. So it will go for another, so their experience tells that, and they are doing 44 years back with 80 suture probably. So these are the issues will come, what Vikas was telling, the Australian registry of keratoconus, DALK versus PK. So still I believe that, that's why I do not jump, it is stress on you only. Admit? Okay. Now come to my talk.
Who should be doing DALK then? Should become young people like me.
Yes.
I think the debate on endothelial rejection is undoubtedly the only single point in
nowadays
favor of PK.
we don't see endothelial rejection that much like in older age. And that is one side of the story. But if you say that
Right,
is,
I had a PK done 22 years ago who came in yesterday. Cell count of 830, 6.9 vision.
so that is what I am trying to tell you. Even when DALK stromal rejection happens and people forget about that rejection part. I had at least 7, 8 stromal rejection. So things are there both sides. Okay. So Boston Kpro 1 in failed grafts. So let's start with my first case. 72 years old lady. You see that both eyes had glaucoma, PK several times, ameth glaucoma valve, and actually I did a third graft, and again graft failed after 6 months, HM vision. I took up this patient for Boston Kpro 1 because all the parameters actually fitting with Boston Kpro 1. No VR pathology and USGB scan showed moderate cupping. We did UVM and IOL was in position, PAS was in some place. So, so this is a very good candidate for Boston Kpro 1, but on the other hand, it is a poor candidate for Kpro repeat PK. Because the next graft survival, we know that only the graft survival will be like 15%. The first patient was doing when she died in 2011, and she was happy with 6/12 vision for last 3 years of her life. So Boston Kpro 1 actually invented by Dr. Dolman, approved by FDA in 1992, PMMA material, recently with titanium backplate, and it is the most widely used Kpro in the world. In 2016, more than 10,000 Boston Kpro implanted since inception. 2002, it was only 50. So it has the longest track record of in terms of Kpro retention and long-term result. It is one step simple surgery, maybe with IV sedation or under general anesthesia. Simpler and faster than any other Kpro procedures. It requires about 1 to 1.5 hours to complete. Visual improvement is just like magic. Maybe on the next day patient may get 6/9 or 6/12 vision. It is also least costly for our country because we get at a subsidized rate. The parts are front plate and back plate, so we sandwich the tissue, donor cornea and titanium locking ring. Nowadays the snap-on design with the back plate is available, and the back plate is also of titanium variety. There are 16 holes in regular, but in pediatric type it is 8 holes, both in titanium and PMMA variety. So this was one of the case, like we take the measurement of, this is a repeat fail graft, 4 times repeat fail graft. So the assembly is the only part we have to do it very carefully. Normally the donor cornea is 9 millimeter or more. If we choose 16 holes back plate and then central 3 millimeter trephine. So this is central hole, and there are the this is the case where it comes. So adhesives are there. So you keep the adhesive in the front plate over the over the adhesive part. Then you put the donor cornea. Little bit of viscoelastic sometimes. This is white part is called pusher. Viscoelastic, and so that it dries upon, so it should not dry. Then the back plate, again you use the pusher to push it down. Then the titanium ring. Titanium ring, it has to be very carefully fitted, and you hear a typical click sound when it fits snugly with the slot which is there with the front plate. Then you shift the whole thing into the carrier box, and rest of the part is like your PK procedure. So there are certain things that lens management is a problem. Many people used to do earlier with ICC, but normally I prefer to do ECCA with plano plus or minus 1 diopter IOL. You may need to do the IOL removal or exchange, iris management, ameth glaucoma valve, anterior vitrectomy, and sometimes I combined with lateral trachygraphy. So the indication of AGV is previous glaucoma. The dictum says that the patient was getting glaucoma medication earlier, so you combine with ameth glaucoma procedure. If there is extensive pass, UVM gives us clue, usually in the same sitting, but it may be on 2 sittings. This is one of the patient. You see that 51 years male, railway employee, only eye, 6 PK in 7 years, 360 degree vascularization, pro strap, only PL. And the thing is that the patient is still going 624 after 8 years, and he is still maintaining his job in Southeast Railway. Auto Kpro is similar to Boston Kpro 1, but somehow the results, I didn't like it. Still they are in the process of evolution. They need to improve their design. The power, etc. same, only the backplate is PMMA. So this is the patient recently, 2015 came to me, CHED in the right eye and left eye. You see that it's a 5 failed graft in 6 years, and this is the day 1 picture, and the parents didn't allow to touch the left eye. What जो भी करना है दाएं आँख में करो. So the keratoprosthesis, the outcomes and the complication, Kpro retention rate is between 65 to 100%. Commonest complication is RPM, retroprosthetic membrane. The second one is glaucoma. Endophthalmitis is also very important, and sterile vitritis. Learning is still going on. So if you see that I have done Boston Kpro type 1 around 96, and the commonest indication in my series is repeat failed graft, then severely vascularized curve, and another group is Steven-Johnson syndrome. Repeat Kpro, you see that there is also 7 in the list. Re-Kpro, so a lot of new things I have learned during these last 10 years. So many new terminology, and I also try to learn the patient address. It's very much important for me, and counseling is very much important for me. So counseling, patient address, case selection, whatever I learned. So initially I was too euphoric. First 3 years I did almost 40 Kpros. Now last year I did only 6. Every year my number is now between 6 to 8. So RPM again commonest in my series. Secondary glaucoma is quite often. Stromal melting is happening. And if you see these are the beautiful retained Kpro with glaucomatous optic atrophy. At that time I didn't have any idea. This was my early cases. And you see the stromal melting, and directly I have done the second Kpro without intervening with therapeutic keratoplasty. Infection I see in my series total 16. It is the dreaded complication, and it is very difficult to salvage this patient, and risk factor are PED, BCL issue, poor follow-up and poor case selection. Probably the geography is very important here. The outcome of infection, we did 7 therapeutic PK, vitrectomy in 7 eyes, Re-Kpro in 5 eyes, evisceration in 4 eyes. So in my total series, the Kpro retention rate is 68.5% over a mean follow-up of 37 months. Recently I have changed my dialogue. Like I talk about 5-year retention or 5-year functional rate. I say up to 5 years your retention or vision will remain 50%. So it is 50-50. Recently, last 2 years, my dialogue has been initially, okay, jitna din chale do. Abhi 50%, I know the 50% will be losing their vision or retention problem in next 5 years. So this is my favorite slide. So you see these 3 circles: surgery, case and follow-up. It's like marriage. Boston Kpro surgery is relatively easy. Just do marriage. So that just do surgery. Partner selection has a little bigger role. So you have to choose the right partner. That is the case selection. Third one is the keeping the honeymooning period for a longer period of time is the biggest challenge. So you have to play with your partner so that they should come for regular follow-up so that they maintain their compliance. Thank you very much.